I'm not sure if you've thought about that question. Of course, if you're a financial whiz kid and you're making lots of money on the stock market, you know full well that there is that appetite for risk. And you can tell your stockbroker that you will not invest in unethical products or tobacco products or whatever else is. And he will make sure that your portfolio fulfills those criteria. I wonder if you thought about the same approach to risk in your surgery or in your operating room. Because in fact, we live in a very high risk area. Sorry, this is a little bit crowded, this slide. René Amalberti was a psychiatrist. He was also a pilot in the French army. He is now one of the gurus in France around clinical practice improvement methodology, and a wonderful guy. And he's focused on risk, and he's produced this graph across multiple industries, which shows where we sit in terms of accepted risk. Accepted risk. And if you have a look on this graph, you can see that anesthesiology for ASA1 cases, pretty much the best cases you can have, is relatively low. It's not quite ultra safe, but it's safe. If you have a look at cardiac surgery in ASA 3 and 4, it's actually very unsafe. Mind you, of course, doing nothing in some of those patients is even more unsafe. Well, we need to understand that. But we can actually categorise risk. Have a look at road safety. It's in the middle of the picture, and I can show you data from New South Wales that shows the dramatic change since 1934 when we saw a sudden increase in risk on our roads in New South Wales right through to the current day. And the risk went very high, suddenly fell with the introduction of seatbelts and random breath testing to below 1934 levels. And it just started to climb again, and all the roadside signs are now telling us about the increasing number of fatalities on our roads, because people are beginning to say this is an unacceptable risk. And one of the things about looking at risk is to decide whether it's acceptable or not. Have a look to the right of the slide down the bottom, and you'll see that railways are considered to be one of the safest industries that there are. In fact, the only one that is more safe is the nuclear industry. We won't have a debate on whether we should have nuclear power or not. But let's actually use the railways as an example of how to manage this problem about risk. I'm going to shorten this a little bit because I know we're running a little bit late on time. This just shows two of my passions. The first was cardiac surgery, where you had to be a team player, up to 15 people in the operating room for an average routine case, and more for complex cases. My other passion, of course, is steam trains, and some of you know that I have a passion to drive steam trains, and I'm actually driving or participating in a driver course here in Sussex in the UK, and I have a certificate that allows me to drive a realised steam train under supervision, not otherwise. And each of the people on that platform, or the footboat as we call it, are interesting. One was a Czech pilot for BA, one was an operator of a drag mine in the Midlands. The guy right at the back, whose face you can just see in profile, was the instructor, and the lady was his wife, was his daughter, and she's a qualified steam train driver as well, and she can shovel coal like the best of them, believe me. But the railways were safe, but the railways are quite unique. They actually have a fixed structure, a very fixed structure. I don't think I need to explain this slide to you, but it actually depends a lot on the track, and the track actually provides quite simple guidance for railway traffic around the world. We'll come back to that shortly. But when you go on a train journey, Will Rogers said, even if you're on the right track, you'll get run over if you just sit there. And that's true of what we do. If we keep doing things the way we've always done them, we will eventually get run over. I had a discussion just the other day with a surgeon who'd had a child under his care have a potassium overdose and almost die. Had a cardiac arrest, in fact, but was amazingly resuscitated. And we asked why he continued to have a protocol which was separate from the rest of the hospital. And he said, I've always done it this way, and I've never had this problem before in 25 years. To which my response was, respectfully, sir, you can never, ever say that again, because you've now had once. Will you accept it a second time? He's currently rewriting his policies, because it's an unacceptable risk, particularly in a child. The railways ran their first fare-paying train line between Liverpool and Manchester in 1830. Less than 12 years later, they actually produced a parliamentary report into railway safety. When did we start doing that in healthcare? About 500 years after we started doing surgery. We're pretty slow. But they actually had a coding system. Very simply, Class 1, something beyond the control of the passengers, 24 accidents and 72 people injured, 24 killed. Class 2 is where the passengers contributed to their own downfall, getting drunk, wandering across the line, sleeping on the line, trying to jump off moving trains, and likewise, that's pretty good. We can always blame the patients for being too sick or too old or too frail or too many comorbidities. They had about the same number of deaths and serious injuries. But note here, and this is really important again when it comes to leadership, Class 3, this is an exact copy, by the way, or I've copied it from the parliamentary report. The asterisks and the quotes are all there. So Class 3 were called the servants of the company. We would call them our staff. They had a slightly higher number of accidents. They had pretty much the same number of deaths and injuries. But the footnote in the parliamentary report said, note, this return is incomplete. No requirement to report accidents which are not of a public nature. So what happens to our staff doesn't count, was what they said. That's the way we often treat our staff in our teams, in our operating room. If we want to improve our performance, we really have to have good teams. And by the way, that first day of the railway is what prompted the report 12 years later. Because on the first day, which was Stephenson's rocket, not only was it the first passenger train, it was also the day of the first railway accident. And a guy called W.R. Huskisson was injured and ultimately died of his injuries. He was an MP who was predicted to become a future PM of England. Some people say that was the only good thing about that particular day. But it was also the day of the first railway accident and obviously the first railway fatality. And we need to understand why the railways adopted a motto, railways the safe way, and they set about some absolute rules to make sure that rail travel was safe. I talked about this morning, and it applied also to the railways. By looking at those reports, they began to make significant changes. What is it that keeps a train on the track? It's not the flange. That is the failsafe when all else fails. Actually, it is the way in which the rails are shaped and the wheels are shaped. And without going into the physics, because we don't have time, the rails are slightly rounded, the wheels are sloped, so that as the train starts to go around, or the track starts to go around a bend, the speed of the wheel on the outside increases, so it goes faster. That's a law of physics. It's immutable. It always happens. So you don't really need to have the flange unless you're going very slowly or very fast. And what we need to do is to understand that the railway is safe because there are rules which cannot be broken. Okay? One of which is to go through a red signal. If you drive through a red signal in most railway systems around the world, you are sacked on the spot. There is no argument. Okay? Signal at red, SAR. It's a fatal career move. How often do we tolerate dangerous behaviour that we don't need to tolerate? The railways said they're not going to do it, which is why they became one of the safest forms of transport globally. But railways also had an interesting experiment with the size of tracks, and the three most common sizes are here, and these are the three that were used on the mainline gauges in Australia before and after Federation. So 5'3" is broad gauge, 3'6" is narrow gauge, and the standard gauge was 4'8½", which came from England and which New South Wales adopted and the other states did not. Crazy. Three different protocols, if you like, for mainline traffic around the coast of our great country. Okay? Do you think that's a sensible idea? It started because people competed. They thought they had good reasons. Queensland had narrow, windy passages, so they wanted a narrow gauge. Victoria, with its open plains, can go for a broad gauge, which is much more stable for heavy traffic. Sounded like a good idea, except that as things changed, if you wanted to go from Brisbane to Melbourne, you would go to the Queensland border where you'd get off the train, cross the platform, get on another train of a different gauge and keep going. If you had freight, they'd actually wheel the freight train into a big siding with a gantry. They'd lift the carriage off the bogies onto the line with the now standard gauge and drop them on and off you go. Huge time and inconvenience and cost. Then when you got to Albury, you did the same thing to get onto the broad gauge in Victoria. Craziness, absolute craziness. Now, come with me to my hospital, Prince Alfred, which amalgamated with the VA hospital at Concord. We were all cross-accredited and we worked in both hospitals. And as a cardiac surgeon, we prescribed a lot of warfarin, okay? But so did the cardiologists, so did the neurologists, so did the neurosurgeons and a few other people as well. Guess how many protocols we had for the administration of warfarin across those two hospitals, which were only 20 minutes drive away from each other? Some numbers? Call out a number. 5? Any advance on 5? Going once. 20? Pessimist. 9. 9 different protocols across essentially only 4 departments in the hospitals. I mean, I'm sure there were other funny things that we didn't know about. So, who are the stupid people? Railways or health? And we tried to amalgamate. We got it down to about 3, and we didn't get much further past that. The lessons from that are that simplicity is really important, and we've got to find the right points of contact and have the gauge just the right size for the best outcome. And remember that simplicity in clinical guidelines is optimum, and that they should follow natural rules that make it hard for us to make mistakes. We don't have time to talk about human factors, but there are natural rules about the way you and I perform, which we can use to great advantage to get our protocol simple and standardised. But of course you have to have the backup and the safeguard, the flange, when things don't go right, when they're happening too fast or happening too slow. One example as to how this works comes from New South Wales. Many years ago now, we had a blood transfusion improvement collaborative, and we established a series of guidelines on when you needed to be transfused and when you did not. The data I present now is about elective surgery in a non-bleeding patient. Okay? And it's not just cardiac surgery, it's all surgery, but non-bleeding patients. And we compiled data across the state which showed the differences in the amount of blood that was being given to patients in peer groups. So this peer group happens to be rural-based hospitals and showed how much more blood some hospitals were giving than were others. And you can see a huge variation between Hospital 4, which was actually using 10% less blood, than Hospital 2, which was giving 65% more blood. When we asked hospitals which unit they were, none of them said they were the best. They usually try to be the second best, or sometimes they'd say, very humbly, they were the second worst. One hospital who had an 80% increase in blood usage, when they were told about that on a Tuesday night in a special meeting that we had, went away to have a look at it, and the chairman of the transfusion committee came to me the next morning before Grand Round and said, we've solved the problem. Because what we found was that our protocols said to the laboratory technician, if you have a hemoglobin and it's less than 9, you must ring the intern immediately. This is a country hospital. Interns are there for a rotation of 10 weeks. So at 2 a.m. in the morning, they get a call from a laboratory technician that says the hemoglobin is 8.9. Right, protocol triggered, let's give a transfusion. We know 2 units are better than 1, so let's give 2. And they were giving 80% more blood. Okay. They changed their protocol to a very simple blow-tie diagram, which is the one that our commission had developed over a series of years with a lot of input from George Rubin, and James Inspistra and their team. Very simply, there is very good reason why you should transfuse people if the hemoglobin is below 7. It's not a safe place to be in an elective situation even. If your haemoglobin is greater than 10, in the literature, and we did a huge meta-analysis of the literature, there was no evidence that transfusing an asymptomatic patient with a haemoglobin greater than 10 if they had no symptoms. No evidence that they should have that whatsoever. One patient got transfused when the haemoglobin was 19, 2 units. Don't ask me why, but they did. In between, there's the area of clinical decision, and that was based on symptoms. So to change the protocol, we've had a sticker put on the blood transfusion sheet which said haemoglobin, symptoms, indication for transfusion. A very simple sticker. It was only about this big. And the residents had to sign that. And it worked. We also had an education program, and we put that little diagram on a card and put it on the lanyards for all our RMOs, and they had to do a 1-hour online blood transfusion learning exercise. When we actually had a look at the pre-transfusion haemoglobins before we did anything, you can see here the number of patients whose haemoglobin was greater than 8 who have been transfused. When we started putting out the guidelines and education of clinical staff, you can see a lot less of the transfusions were in that high haemoglobin group, and it was much more appropriate. But then we actually put another gatekeeper exercise, which was simply, you can't give a blood transfusion to a patient outside of the protocol without talking to the senior consultant concerned with that patient. And look what happened. Whoops, sorry, I've gone past. Now you can see that we've dramatically reduced the number of transfusions given. In fact, across the state, for 4 successive years, a reduction of 10% in the number of transfusions given. 12,000 less transfusions. Many millions of dollars saved for the CFO, kept him happy as well. The consultant said, oh, that's terrible, they're going to ring us all night. Well, it didn't happen. They only had to ring twice, and the resident be asked, well, what does the guideline say? If it's in the guideline, you just go ahead and give it. If it's outside the guideline, thank you for ringing. I think this patient's a special case. Do it or don't do it. 2 points of contact. Made it easy. Followed the natural rules. And we changed transfusion practice. At the same time, in the other states in Australia, transfusion volumes were increasing by 25%. We had made a dramatic difference. So if you do easy things, if you have clear automatic guidelines and prompts, follow natural rules and standardise it, you actually start to change behaviours, both in the railways and in healthcare. Now, we're going to have to be pretty quick here. There are a series of accidents in Australia. This one occurred in 1977 at Granville. It was our worst railway disaster ever. No one was found to be at fault. The train swayed, hit a stanchions and went underneath a bridge, and the bridge collapsed on it and 83 people died. We could spend a lot of time talking about this. Basically, the engineers of the bridge decided the bridge was very rough and ready, and they put another layer of concrete across the top of it without thinking about the impact on the stanchions. So when the train just gave it a gentle nudge, the stanchion bent, collapsed, and people died. The point being that disasters can occur for external reasons that we have no control. We think we have no control over. And they can occur during normal activity, and we need to be prepared to respond to the immediate risk as it happens, because only a few people can see it coming. If you read the stories of that disaster, there were some horrific, pathetic stories of people who stayed in the carriage, even though the train had come to a halt before the platform collapsed on top of it. Accidents can occur when rules are being obeyed. Okay. This is not a fail-safe system that we work in. But the practice response is what saves lives in the railway disaster and in the operating room. The best performing groups of the railway disaster were actually the Salvation Army and the Red Cross. New South Wales did remarkably well, and they really saved quite a number of people from their serious injuries. In 1999, there was another accident, and this one's very briefly described, is that train number 1, our Crack Express from Perth to Sydney, was going through the Blue Mountains. It was a foggy morning, went round a corner, there was a red light, and it stopped correctly. It rang Radio Central to the control room, and they said, yes, there's a fault with the signals, you may proceed, but proceed slowly. So it moved on, and went about a train length around the bends and through the cuttings to another red signal and stopped and rang Radio Central, but there was no radio communication. So they stayed stopped. Okay? They obeyed a rule. Meanwhile, behind it, the Interurban electric train, who'd heard some of this, didn't hear anything more from the train and assumed everything was safe, and also went through the first red signal and kept going and ploughed into the back of the India Pacific. And a number of people died, 7 of them, 50 critically injured as well. And we need to understand that if we're out of communication with our team, accidents can occur even though we might have the best will in the world. Where's the consultant when somebody's doing a new operation? Do you know how good they are in that circumstance? How many of those they've done? Have they had any complications and so on? Or are you home in bed? I'm not picking on the consultants here. I'm picking on the system. The safe working rules were deliberately broken. Okay? They allowed the train to go through the first one, and they probably should have stopped it there because it would have been apparent to the oncoming train long before he ploughed into the back of this particular train because of where they were at the station. There was a big inquiry and a safety audit was promised, and one of the things was they were going to put data loggers in all trains. So we need to understand that warning signs need to be heeded, and no one knows better than those safety rules that have been applied as a result of massive experience across the system. Okay, you know, the person says, well, I've always done it this way, I don't have that problem. And we can show them hundreds of thousands of case stories where the percentage showed it happened 10% of times. No one knows better. I'm rushing through this, I know, I'm worried about the time. 4 years later at Waterfall, another accident occurred. On this occasion, the driver had left main coronary artery disease and had a heart attack and collapsed. He did not trigger the dead, or he continued to trigger the dead man's hand. I'll tell you why in just a moment. The train gathered speed, it started to rock, it hit the sandstone wall, then derailed, and again, 7 people died. They tried to ring for help, it was out of telephone range again. The safety audit recommendation hadn't changed, nothing had been done. They had also promised after the first accident to put roadways alongside all the tracks to widen the cutting so you could get vehicles to a train anywhere. They couldn't do that at Waterfall because they hadn't actually widened the cuttings. And the fail-safe mechanisms didn't work. The dead man's handle didn't work. Strangely enough, I heard this from Bob Henderson yesterday because he's done a bit of a review of it with other people, that the guy was obese and he fell onto the hand. There are 2 handles, one on the use your hand and one for a foot pedal. He fell onto the hand piece and his weight was such that he kept it depressed, which means the train keeps going. And the way he fell, his leg was rigid and rigid enough that he actually kept the pressure on the foot pedal down as well. Now, who could possibly think that might happen? We now know it can happen. And people have made design changes to the cab to minimise the chance of that occurring. But we need to recognise that the safety culture nevertheless hadn't changed. In fact, there was a feeling around about the data loggers that said, look, no, we haven't had an accident for 4 years. The last accident before that was 22 years. There's no rush about the data loggers and no rush about getting the roads right. And they relied on accident trends to their peril. So real-time data means we have to act real-time to put safety measures in place now. Communications must work. It's no longer acceptable to say, I couldn't find the right person. That should be part of your briefing process. If we get a struggle, who do we call? Hazards must be identified, training is critical, and resourcing is crucial. But we have to take that information back to our operational and financial officers in a framework that says this is best for the community, for the voters, therefore for the minister. Now, one final story. Have I got enough time to tell this story? Thank you. This didn't occur in the press, not the way people thought anyway. And it took place on Easter Sunday in Easter Saturday in March 1990 in the Blue Mountains. Being a railway aficionado, when we bought our little holiday cottage, it was right next to the railway line. I used to keep my camera on the front veranda in case there was an interesting train going by. And we were there over the Easter holidays. And I woke up about 5 a.m. on the Saturday morning and I said to my wife, there's something wrong with the track, it's making a different noise. She told me to roll over and go back to sleep, but I was a bit anxious. You know when you walk onto a ward and something just doesn't look right? It's messy or it's smelly or something, and you know it's not right? Or you walk into an operating room and you know the atmosphere is tense and you know something's not right? That subconscious feeling is part of experience, authority and influence. So I couldn't go back to sleep, so I got up and got dressed and started to wander out the door. My brother-in-law, who was staying with us, asked what was what, and he came with me and he had enough sense to pick up my camera. And we walked over and this is what we found. And you can see here, this thing here is called a fish plate, and it's a series of bolts which hold two ends of the rail together. It just so happens that this was near a point, and this piece of rail here moves and it pivots on this fish plate. And the bolts had fractured with repetitive movement, fallen through, the rail had moved, and you can just see here that there is already damage to the rail that was probably the noise of the coal train going through that I'd heard earlier that night. So I said, we've got to get help. So I walked along the track about 100 metres or so to the station. It was unmanned because it was Easter Saturday, public holiday. I walked down to the police station, which is 2 blocks away. It was unmanned because it was Saturday and a public holiday. But there was a phone through to Katoomba, our major town in the mountains. And I rang through and got onto a constable who clearly thought I was hoaxing. He just simply wasn't interested, had no idea what I was talking about. So I said to Boyd, we better hop in the car and drive down to Katoomba. But as we walked back across the tracks, I spied a highway patrol car. And we walked in the fruit shop and there was a guy buying his breakfast or his lunch. And I told him what the problem was and he told me to F off. And I said, look, I'm terribly sorry, officer, but this is a serious problem. If there's a derailment, it'll be on the front page of the Sunday Telegraph tomorrow. I've noted your service number and it'll be there as well. He said, and came and had a look, saw this track and said, well, what the F do I do now? I said, you've got a service key. If you go down to that little brick building there and you open it, there's a phone in there which goes straight through to Katoomba signal box. And I can tell them what the problem was, and that's what we did. About 20 minutes later, this guy arrives on the scene. He's what they call the fettler, the guy that looks after the track, and he's in charge of the track over the Blue Mountains. He happens to have severe gout. He couldn't lift the spanners because they're pretty big out of the truck. In fact, you can see how big the spanners are because that's me putting the last refining turns on the bolts that I'd replaced in this piece of rail. I said to him, where's your crew? He said, it's Easter holidays, they're off playing soccer with their kids, I can't find them. I said, mate, I know a little bit about railways, I'll give you a hand. I'll get the spanners out. So I knocked the old bolts out, put the new bolts in, and I was tightening them up. And he said, what do you do? I said, oh, I'm a doctor actually. And he said, what sort? I said, oh, a surgeon. Oh, really? Okay, what sort of surgeon are you? I said, I'm a heart surgeon. And he grabbed my hand and said, stop, you can't do this. And I said, why can't I do this? He said, because you don't have indemnity, insurance. I said, oh, come on, forget the indemnity. Railways are very big on indemnity and on insurance. I said, forget the indemnity, I'm having the best day of my life. And I finished the job. He went back down to the signal box and he came back and he was pale. Both Boyd and I noted he was pale. I said, what's the matter? He said, do you know what the next train through here was? I said, I imagine a coal train. That's why I was worried. I didn't want 90 tonnes of coal in my front yard. He said, no, it was train number 1, India Pacific. And the sort of carriages would have derailed with a track fault like that for sure. I told my dad, who was a railway man, who got my interest in railways going, and he, as a cynic engineer, fitter and turner, said, probably saved more lives today than you did in the rest of your career put together. Maybe so, maybe so. It's that simple sometimes, isn't it? At any rate, he died about 6 years later. And when I was going through his belongings, I found a copy of the report that my mum, who was the legal secretary, had typed up for me, and a copy of these photographs, which I had to send off to the fettler who's going to deal with it because they had to put a report in and they wanted the details. I hadn't heard nothing from it. So I decided I should contact the new Railway Commissioner. And I sent through a little note. He replied within 3 days and said, haven't quite yet found the file yet, but I like the photos and it's an important story, I'll get back to you. Within 3 weeks, he got back to me with his second letter, which included the photos and the original letter that we sent through, and said, you undoubtedly saved a disaster. Is it okay if I put that in the staff magazine so other people understand what you had learnt? I said, no, go right ahead. An 8-year turnaround in the feedback loop. Longest feedback loop in history, I think. Twice as long as the time between those last 2 accidents. It could have happened again if people hadn't got the message to check the track. Or, as Dad had said to me always when I was a little boy going out with him to hear trains, listen to the rhythm, Cliff. Listen to the rhythm. If we want to avoid risk, we have to learn to listen to the rhythm. When you walk onto a ward and it looks messy and people are anxious and there's papers going everywhere and you can tell the staff are cranky, listen to the rhythm. When you walk into the operating room and the operating team aren't talking to each other and the anaesthetist is running around looking extremely worried and thinking, where am I going to get more blood from? Listen to the rhythm, because that's where we actually drive the change. And remember that even good guidelines, when they're broken, can be dangerous. Persistence in reporting up, in speaking up, is crucial. Please do not discourage your staff from telling you what's going wrong. Reporting mechanisms must be available, and anyone can help. Even a surgeon can fix a railway track, as long as they speak up. We do need incentives to encourage people to speak up, and I like the idea of rewarding good behaviours, and chocolate's not a bad way. It's probably not nutritionally correct, but it's pretty enjoyable just the same. And near misses are invaluable lessons because you have survivors to tell you what went wrong and how you solved the problem. That's the way to manage risk, to minimise it, and absolutely on occasions to remove it. Thanks very much.